Hi, occupational therapy students. This is occupational therapy OCC 222, and today we're going to talk about the neurological consequences of diseases. This effectively is a time to stop and reflect on the conditions we already know and other conditions out there that have neurological impacts. We already know that there's several causes of nervous system dysfunction, from trauma to lack of blood flow to autoimmune diseases to infection to general degeneration, even structural defects. And this includes things like spinal cord injury, cardiovascular accident, a peripheral neuropathy or carpal tunnel syndrome, for argument's sake, maybe something like Guillain-Barré, which is an autoimmune disease, infections such as meningitis or degeneration. But there are also other conditions that also affect the spinal cord and the brain and general nervous system. This eLeccture will cover some vitamin deficiencies, namely B12 and B1, connective tissue disorders and their impact on neurological functioning. Diabetes is a condition which is probably the primary systemic condition we'll be looking at today, and some infections. One of the intended learning outcomes for you is that you understand the occupational implications of living with epilepsy and living with diabetes as two major conditions to consider. Let's start off with vitamin deficiencies. These are characteristically a B1 or a B12 deficiency. B1 is effectively a thiamine deficiency, and in our first world environment, we generally tend to see it as a secondary to alcohol abuse. So if someone uses alcohol for a really long time, they end up with a thiamine deficiency, which ends up precipitating in a Wernicke-Korsakoff syndrome, which effectively means some cognitive and some brain damage due to long-term alcohol abuse, which has a presentation having nystagmus or optical. So nystagmus meaning the eyes moving too fast and stimulatedly, ataxia, confusion, and possible psychosis. So that looks a little bit, you can understand, we talked about the cerebellum in previous lectures, so you understand how this looks like it really has targeted the cerebellum. B12 deficiency is more common in people who maybe lack good nutrition and might be obvious in occupational therapy settings when you do a home visit and see an older person who isn't eating properly. That means that they sometimes present as having some sensory neuropathies peripherally. They might have memory loss, confusion, fatigue. You might think of this as a dementia, but on examination and on treatment, it actually can be reversed. So really important to recognize that vitamin deficiencies themselves can actually cause neurological conditions. So what we see in clinical practice isn't always purely a neurological condition. Because it's all connected and the nerves are in the human body, the vascular and connective tissue disorders can actually cause nerve disorders. So if you have something like a lack of blood flow due to thrombus or embolism to a part of the body, and that lack of blood flow actually then causes a lack of blood flow to the nerves, the central nervous system, the peripheral nervous system, you can end up with a neurological complication that was purely due to lack of blood flow. Similarly, if your connective tissues are very tight, such as in carpal tunnel syndrome, you might end up with an entrapment. So because the conditions are really tight or everything has got tighter, that means that the nerve itself might not move, which means you end up with something that looks like a neurological condition, which is primarily actually a connective tissue disorder and is treated by removing the connective tissue rather than trying to target the actual nerve. Infection is also a possible cause of central nervous system or I should say neurological dysfunction. In the central nervous system, it might be in the meninges, either viral or bacteria, or it could be in the spine or the brain in terms of an abscess. So in a brain abscess, it could be secondary due to a middle ear infection. Even sinus infections can cause brain abscesses, or bacterial endocarditis, or even a skull fracture can cause a brain abscess. In the spinal abscess, it's normally epidural, meaning on the outside. Might be from skin infections. Even a urinary tract infection can cause a spinal abscess. So these are pretty unusual and extreme conditions where we see things happening in the spinal cord or in the brain due to an infection or a state of infection. We also have to be aware of some diseases, when not treated, actually become neurological. So something like tuberculosis, syphilis, and malaria are all conditions that normally with normal treatment don't affect the spinal cord or the brain. However, if they become untreated, you end up with possibility of TB meningitis and TB spine. Picture on the left is a picture of an x-ray and what happens to some children in developing countries where they have TB that isn't treated. The TB then migrates into the spine and causes some serious bone collapse, which then causes spinal conditions and often can cause paralysis. Neurosyphilis is another one. If syphilis is untreated because it goes through a stage where it seems to have recovered, it actually evolves or migrates and turns into a neurological condition which causing some serious psychiatric and cognitive disorders. Malaria is the same. It has the possibility of being a malarial, cerebral presentation, and Lyme disease, which is technically not reported in Australia, but is debated as to occur here because it's something that's carried by ticks. Other general conditions that might have a neurological presentation, if you have a disorder in the pituitary gland, that will cause a neurological presentation. Electrolyte imbalances, so any form of imbalance that you don't have the right amount of sodium, potassium, magnesium, calcium, can actually cause a hostile environment for your nervous system, which means you get a disturbance to your central nervous system, peripheral nervous system, which means that you don't function normally. This is normally quite treatable. However, if it's very sudden, it's a sign of worse prognosis. Then there's anemia, if there's not enough blood, which means you have possibly loss of dizziness, or not the loss of concentration and the appearance of dizziness. Not that this is a particularly a neuro condition, but anemia does have obviously a sort of neurological presentation. Gastrointestinal disorders are pretty rare in terms of neurological complications, but sometimes a hepatic or a liver disease can cause an encephalopathy, or even a celiac disease can cause a kind of ataxia and a neuropathy. So they're pretty unusual, but just to bear in mind that it's all connected. So if any part of the body is affected by illness or infection, it is possible the nervous system will also present with some kind of disorder. Now we move on to one of the main topics for today, and that's really the condition of diabetes. So for this course, we don't expect you to understand the ins and outs of the hormone imbalance that is or that causes diabetes, but what we need to know is the presentation of diabetes and its neurological impact. So everyone is well aware that diabetes is the most common metabolic cause of neurological symptoms. It's also one of the most common diseases we have in Australia. There are two presentations of diabetes in the worst case scenario. That's when they have too much insulin, where you have low blood sugar, and this is called hypoglycemia, or hyperglycemia, when you have too much glucose, and then you can end up in a coma. If someone has too little blood sugar, they end up dysarthric, maybe have agitation, confusion. Effectively, if you think about it, the brain doesn't function normally when there's too little blood sugar, and again can cause a coma. So either too much blood sugar and too little blood sugar can both cause coma. So it's really important to realize that diabetes is not just a metabolic condition where we have to get people's sugars right. It actually has a neurological implication and can cause coma and effectively. Diabetes also seems to affect the arterial walls. It changes the blood pressure or changes the way the blood is pumped, and it seems to increase the risk of atherosclerosis, which is done because you end up with medium and large arterial wall damage. Atherosclerosis is something we've seen in cerebrovascular disease or cardiovascular disease. So we see things where the walls are weakened and then they get lined with plaque, and that plaque decreases the blood flow or causes a kind of embolism, and that causes a stroke. So in the smaller vessels, we call that a multi-infarct dementia. In a large vessel, it's normally a stroke. So there's a really strong correlation between diabetes and stroke, but there's also a correlation between diabetes and neurological dysfunction, particularly autonomic system dysfunction, as well as things like dental complications and kidney disease, which is normally called a nephrotic system. But we're just going to talk about the neurons and how diabetes affects the neurons. This diagram basically is a quick summary of the risks or the associated complications of diabetes. Obviously, as we mentioned before, stroke, because there's an increased chance of cardiovascular accident because of the atherosclerotic plaques and the decrease in the change the structure of the wall, the vascular wall. Likewise, similar to stroke, there's a chance of a heart attack. There's also diabetic retinopathy, which is quite common, so optical differences, damage to the kidneys, as well as this neuropathy, which is what I want to talk about. It's a diabetic neuropathy picture that sort of explains a bit what happens in neuropathy. Because the blood vessels are affected by diabetes, it means that the nerve doesn't get all the oxygen and the blood that it requires, which means it actually wastes away. So you end up with a diseased blood vessel, and a diseased blood vessel results in a shriveled or a damaged nerve. So this is more common in the peripheral nerves because we mentioned this before. You end up with a glove and stocking presentation because the damage is worse the further away you are from the heart or the further away you are from general good perfusion. So it's very common in the distal areas, the fingers, the toes, and can spread. It's normally quite symmetrical because when the disease happens, it means that the blood is not getting to both feet or to both hands. It seems to have it's more common to have a sensory presentation, so more likely feel tingling or a change in sensation rather than actually seeing motor dysfunction. That is possible. And with it also sometimes comes compression such as the motor neuropathies. And I mentioned earlier an autonomic neuropathy. So people can actually have an autonomic system. So they might sweat a lot, or they might have constipation, other sort of systemic changes that are related to autonomic nervous system. These rather horrible photographs are an example of retinopathy on the left and decreased perfusion on the right. So I'm going to talk about the right hand in the next slide. This is really the risk of amputation because with the decreased perfusion as well as nerve damage, you tend to get the formation of ulcers. So very common in amputation and something that most of us will see if we work in a community setting and especially working with people at risk and people who are elderly, is that untreated or unmanaged, not untreated, unmanaged diabetes can often cause the formation of ulcers. So you see little ulcers, particularly in the distal limbs, like on the feet, the ankles, the fingers, and those ulcers can actually become so severe that they cause permanent damage that can't be overcome. And that means that the only way this can be managed is normally to go through amputation. So actually, if you work in an environment where you're treating people with limb absence or amputation, it's quite likely that you're also dealing with the diabetic population. So as an occupational therapist, not only do you do education about limb absence and living with an amputation, but you actually do a lot of diabetic education along with the team. So OTs actually have quite a big role to play in diabetes. While we might not be endocrinologists and we don't really understand these systemic diseases, we do see the manifestation of diabetes, particularly in amputation, and then we deal with the condition or the disease in totality because of it. Really important to note that this is a very, very big Australian issue. It's particularly prevalent in our Aboriginal and Torres Strait Islander people. Um, People of Aboriginal Torres Strait Islander descent are 3 times more likely to have diabetes 1. They're twice as likely to have gestational diabetes, so that's diabetes when you're pregnant. And even kids aged 10 to 14 are up to 8 times more likely than non-Indigenous children to have type 2 diabetes, which is normally actually an adult disease. So we normally see type 2 diabetes occurring later on in life, people with bad, fairly poor lifestyle habits. But now we're seeing it in 10 to 14-year-old Aboriginal and Torres Strait Islander children. It's also 6 times more likely to cause death in this population because of the conditions and that people aren't accessing the right sources. The little picture on the right-hand side here is this one over here is the National Diabetes Service Scheme. So actually, people with diabetes are really well looked after in the health system in Australia, and they have access to resources as they. I've put in this next slide as well. So we have other resources, including Diabetes Australia, which provides lots of information and lots of links to supplies and things that people with diabetes would need. And obviously, there's also the National Diabetes Service Scheme, as I mentioned in the previous slide. All right, now this is a link to a video about amputation in Vanuatu, which was actually a video created by our occupational therapy 4th year students 2 years ago for one of their final projects. And this is actually about the prevalence of amputation in Vanuatu and how amputation in Vanuatu actually causes a lot of social and occupational isolation. The students, this is just a bit of interest. It's not necessary for examination, but I think it's a nice demonstration of what OT students can do. This is a story. It's a narrative, a social story about a one-legged bird that can still, a one-legged bird can still fly. So effectively, it's a way to engage with the local community to explain the story of a bird who only has one leg and who can still fly, which means that if you have diabetes, you're still able to live an active life. Just this is a nice thing to add to today's workshop.